This lesson on genetic screening is going to focus primarily on aneuploidy. Other genetic mutations and genetic diseases follow similar principles. If you're at risk for having a genetic disorder, you can do a genetic screen. You only do the genetic screen when mom is willing to do the confirmatory testing, and the only thing to do about a genetic disease is to prepare for it or terminate. So it's best not to offer if mom is unwilling to terminate. The idea would be terminate early, try again. In general, it should not be offered if mom is unwilling to take the risk of an invasive procedure. Most moms will try to get a screen done to rule it out. But if she's unwilling to change the management based on the result of the test, it isn't worth doing. Let's start off with discussing aneuploidy, and then we'll get into the general concepts of genetic screening. There are three major diseases that you should know about regarding aneuploidy, and I'll give you an advanced organizer to remember. It's Down syndrome, Edwards syndrome, and Patau's. Down syndrome begins with a D. D is for drinking. The drinking age in the US is 21. Chromosome 21 is affected by Down syndrome. Edwards E, E for election. The age at which you can vote in the US is 18. Chromosome 18, Edwards. Patau is the other one, also can be remembered by PG13. Movies, the 13 reminds you of chromosome 13. The diseases that are named are chromosomes 21 Downs, 18 Edwards, 13 Patau. Risk is going to significantly increase with increased maternal age. And the general consensus is age 35 is the danger zone above which risk significantly increases. But if you take the sheer number, that is the prevalence, what you'll find is that more of these diseases come up in younger women. This is actually very important to understand. There are more cases of aneuploidy in younger women because younger women have more kids. The sheer volume of pregnancies increases the number of aneuploidy in younger women. For this individual woman in front of you, an increased maternal age increases the risk of aneuploidy. The patient presentation is going to be an asymptomatic screen, but you're more likely to do this screen if she has increased maternal age or has had a previous pregnancy with aneuploidy. The diagnostic steps, and we'll talk a little bit more about this in detail in a second, usually involve a screening tool, which is non-invasive, and then to be followed up with, if screened in, to be followed up with a confirmatory test, which is almost always invasive. That is a needle going into baby or the amniotic sac to get genetic material. The treatment for a genetic disorder is termination. With any genetic disease, all options should be discussed, and the decision you make with the mom on what to do is dependent on her belief system, not yours. Adoption, raising the child, or simply termination. The goal then is to be diagnosing aneuploidy as early as possible so that the termination is at least intrusive on mom and more likely to result in a good pregnancy in the future. But the end result of this is going to be termination. So mom comes in and says, you know what, I want a screen. And she's willing to go the whole way. If she's positive and she ends up having a baby with a genetic disorder, she does not want to keep it. So you start off with the screening test. Screens do not diagnose or rule out the disease. They only put mom into risk categories. If the test is screened negative, quote negative, we say that she is low risk. If the test is positive, quote positive, it's high risk. Except for extenuating circumstances, if a screening tool is negative, there are sensitivities and specificities for individual tests for individual diseases, but don't memorize them. Memorize the concept of if screen negative, low risk, stop. If high risk, invasive testing. Confirmatory. If the invasive test is negative, you stop. If it's positive, baby's got a genetic disease. And the main thing to do here is to terminate and try again. So the emphasis then is going to be on early detection. Particularly for Down syndrome, but for all of these aneuploidies, there's the first trimester evaluation. First trimester screening is going to be the lowest sensitivity, but also the earliest intervention. First trimester screening involves an ultrasound for nuchal translucency, which should be less than 3 millimeters, a PA-PPA, and an HCG. There are 3 pieces of this test that help you identify what's going on and if there might be some neural tube defect or Down syndrome. I don't want you to try to remember a bunch of arrows. So just say that's what you're going to get for a first trimester screen. The second trimester screen consists of things that you've probably heard of in first year, but you want to engage them again. This is going to be the triple screen. And if you add 1 lab test, the quad screen. The triple screen consists of a beta HCG serum, AFP, estriol, and to make it a quad screen, you add inhibin A. This you should commit to memory because it's easy to remember. Again, we're dealing with Downs, Edwards, and Patau. Downs is up. To differentiate it between Downs and Edwards, because both Downs and Edwards have AFPs and estriols that are down. They mimic each other and therefore don't count when you're on the test. Downs is up. The remaining 2, HCG and inhibin A, will be elevated. In Down syndrome, Downs is up, HCG and inhibin A are elevated. Edwards is the other one, so it will be down for HCG and down for inhibin A. Also note that estriol levels are significantly low. Don't memorize Patau. You may be asked to regurgitate that information, but I don't think it's worth the squeeze, and if you miss 1 arrow, you miss the whole test. So it's not worth it to try to get a question by memorizing all the arrows. Instead, just know that Downs is up and go from there. But also the concept of combined versus sequential screening. In a combined screen, you wait. You do a first try screen and a second trimester screening without intervening until you have both. Combining them is going to significantly increase the sensitivity. It's good when mom is negative, but because you wait for the second trimester screen, you have limited options. If instead you do a sequential screen, where you do a first trimester screen, and if negative, follow it up with a second trimester screen. But if it's positive, go to invasive testing. If you do this, what you end up with is more moms getting invasive testing. You increase invasive procedures, which effectively increases fetal loss. We talk more about these during the advanced prenatal lecture, where we talk about chorionic villus sampling, amniocentesis, things like that. But because you intervene earlier, you say, I'm willing to do an invasive test in the first trimester, you have increased options and an earlier termination, which makes things easier. These things are becoming moot because we have new technology. This will likely not be on your exam, but cell-free DNA is a hot topic. The idea is that there is fetal DNA in maternal blood. And if this works, you won't have to do invasive testing. You can just know baby's DNA based on a blood sample from mom. It's not happening just yet. And then the genetic tests you want to know about, they're going to be specific to individual populations, to areas of the country. There's a generic screen, but we don't do everything for everybody every time. But the ones you want to pay attention to, as we talked about in the last lesson, cystic fibrosis for whites of European descent and sickle cell disease for blacks of African descent. The main things to take away here is that if you're going to do a genetic screen, mom has to want the invasive test, and she also has to want termination, because if it's positive and you're not going to change your management, it's not worth doing. And you can increase the sensitivity by doing either combined or sequential screening, knowing that there's risks and benefits to each one. Memorize Downs is up, HCG and Inhibin A for the triple and the quad screen. The other ones are different. And know also how to recognize that nuchal translucency and PAPPA are for the first trimester screens. Ultimately, what you want to do is have an early termination so mom can try again and hope at having a successful pregnancy without genetic disease. That is genetic disease screening.